All right, I'm going to go ahead and get started. Um, Hi, everyone. I'm Tamara Kaplan, uh, and it is my honor and privilege to be the featured expert today to talk about bowel, bladder, and sexual dysfunction in NMO and NMO spectrum disorders. I am a neurologist at Brigham Women's Hospital and an assistant professor at Harvard Medical School. I specialize in neuroimmunology and I primarily see patients with multiple sclerosis and NMO and other neuroinflammatory diseases. So I'm so grateful to the Sumaira Foundation and Viela Bio. This program was hosted by the Sumaira Foundation and sponsored by a patient education grant by Viela Bio. And Viela Bio is dedicated to the development of and commercialization of novel life-changing medications for patients and a wide range of other autoimmune and severe inflammatory diseases. And their approach to drug discovery is aimed at providing targeted treatments for the improvement and outcomes of thousands of patients who have few or no therapeutic options. And there's more information available at vielabio.com. So, without further ado, I thought I would spend the first part of this hour just talking about some basics about bowel, bladder, and sexual dysfunction and how these things are related to NMO. And I know that these are really sensitive topics and issues that a lot of people aren't even talking about or might be embarrassed to talk about. So please be open to, I talk to all my patients about these things because I think these issues need to be addressed and they have huge impacts on our quality of life. So please ask me any questions that you might have. So we'll start with bladder problems and we'll talk a little bit about how normal bladder function is supposed to work and then what can sort of go wrong. Then we'll also talk about bowel problems, again, how it's supposed to work and what can go wrong, and similarly with sexual dysfunction. So starting with bladder problems, excuse me. I think one thing that's really important to think about with NMO is there's a lot of symptoms that people have. Independent of relapses and whatnot, people can still have symptoms, like chronic symptoms that are going on all the time. And there can be this sort of vicious cycle of symptoms. So if you're having really bad bladder issues, for example, you might be waking up multiple times a night, and then that leads to poor sleep, and then that can lead to feeling fatigued and and having difficulty during the day, and then that can lead to sexual problems because you may not be that interested in having sexual function if you're feeling so fatigued because you haven't been sleeping and because you're waking up 5 times to go to the bathroom, and so on and so forth. So, I think if we can find one place in this vicious cycle to stop some of these symptoms, we can improve a lot of the other symptoms. And it's really important to remember that no two people have the same symptoms, and no two individuals respond to the same treatment in the same way. So your symptoms are unique, and your treatment will be unique. So let's talk a little bit about bladder anatomy to begin with. We're going to do an anatomy lesson. Basically, the bladder is like a balloon that's elastic, and it can hold a capacity of urine before you feel ready that okay, I need to use the restroom. And the capacity is actually quite large. It's more than a can of Diet Coke. Um, and the capacity is about 600 cc's or 600 milliliters of fluid. Normally, people get the desire to void when it's about half full. Men have a slightly higher capacity than women, and then the bladder itself is a muscle, and then that muscle contracts and then allows urine to come out. And it's not just the bladder that's involved. In order for urine to come out, there's actually two sphincters too. There's an internal urethral sphincter and an external urethral sphincter. And both of those have to relax at the same time the bladder is contracting in order for urine to come out, right? It sounds so simple, but it's actually extraordinarily complex. And between those two sphincters is what we call the urethra. And as you might imagine, there's some anatomical differences between men and women. Men typically have a much longer urethra, and that's also part of the reason that women are much more prone to things like urinary tract infections and UTIs. So basically, what happens is the bladder slowly fills, and then you get this in normal folks, like there's like this sensation of, I think I'm getting ready to go to the bathroom. And then the bladder continues to fill, and then you say, okay, I'm ready to go. And then that bladder contracts and it empties to completion. Again, sounds simple, but all of this is controlled by the brain and the spinal cord, and some of the peripheral nerves as well. So in order for all those messages to get through, we have to involve the sympathetic nervous system and the parasympathetic nervous system, all this whole autonomic nervous system that's all running through the spinal cord, which means if there's any damage at all to the spinal cord, all of those messages can be disrupted, and therefore things don't work as well as we want them to. So what are some of the symptoms when things go wrong? Well, some people can have increased frequency. Some people can have urgency. Some people can have need to go to the bathroom multiple times a night. We call that, the medical term for that is nocturia. Some people can have incontinence, multiple UTIs or urinary tract infections. And some people have retention, like they can't completely void all the way. And these symptoms are so incredibly common. There's less literature about with regard to NMO, but in multiple sclerosis, which typically the lesions are even smaller in the spinal cord, up to almost every single person, 100% of patients will have some bladder dysfunction by 10 years into their disease. So there's different types of incontinence. Incontinence is when urine leaks a little bit, or your underwear gets wet, or your pad gets wet. So there's what's called stress incontinence, and that is the type of incontinence that's not actually due to NMO at all. That is the type of incontinence that some women have after having lots of babies, for example, because there's some weakness of the pelvic floor. And so the way this manifests is when people cough or sneeze or bear down in any way, a little bit of urine leaks out because that muscle just isn't as strong as it once was. But then there's something called urge incontinence, and that's more of what we think about as a consequence of neurologic problems. And so there can be this involuntary leakage associated with this like immediate urge, like I have to go to the bathroom right now, and I've got 30 seconds or I'm gonna leak. And so that frequency, urgency, all those things are the most common types of early bladder changes that we see with NMO. And then sometimes there's also this retention, or what's called overflow incontinence, where there's a failure for the bladder to actually empty. And so people can have hesitancy. You sit on the toilet and this urine's just not coming out as much as you wanted it to. And sometimes people go to the bathroom and then 10 minutes later they're like, I think I have to go again, because they haven't completely emptied their bladder. And what's really tricky about NMO is some people have a mix of all of these things, right? You can have, these do not exclude each other. So some people can have a little bit of overflow and incontinence and retention and urge, and then plus or minus some stress incontinence too. So and then the last sort of very difficult type of incontinence that I'll explain is something that we see a lot with people who have lesions in the spinal cord, and it's a very fancy medical term. It's called detrusor sphincter dyssynergia. The detrusor is the bladder muscle, and then I mentioned the sphincters. So what's supposed to happen, like I said, is the bladder muscle contracts and the urethra and the sphincters relax to allow voiding. But what can happen in detrusor sphincter dyssynergia is that the bladder contracts, and at the same time the sphincters contract. So you're trying to go and nothing's coming out. And that is something we see all the time as a consequence of lesions in the spinal cord. And it can be so disruptive and annoying because people get the sensation that they need to go to the bathroom and have urgency, but then are unable to completely void or empty their bladder. And so this is another example of this mixed urgency and retention. So people can have some leakage and incontinence and urgency all at once. And it can be sometimes really challenging to treat that. And then, the last thing I'll mention too is UTI. So some of you might be familiar with that acronym UTI for urinary tract infection. And UTIs are common. They're very common with people who have what's called a neurogenic bladder, which means bladder problems as a consequence of having, spinal cord problems. And it's sometimes this can even lead to a pseudo relapse in NMO, because people might present just feeling generally not well, a little extra fatigued. They might have increased spasticity, and it might be from a UTI. So it's always something to think, keep on your radar, because sometimes we don't even have the sensation of, we were always taught in medical school that, with a UTI, people are burning when they pee. But that's not always true, especially with people that have a neurogenic bladder. So sometimes these symptoms can be more difficult to detect. But anytime, someone's feeling like they might have new bladder symptoms or something seems worse or different, it's always a good idea to check your urine and make sure there's no UTI. So there's a lot of treatment options, which is the good news. And like I said, no treatment is the same for each person. There's all different ways that we can treat these problems. There's lifestyle treatments and sort of what I call bladder training, which I'm going to talk about in just a minute. There's pelvic floor rehab, which can really help strengthen those muscles down there. And there's a lot of medications. There's a class of medications called anticholinergics, which are the most common, and I'll talk a little bit about some of those. And some people do intermittent self-catheterization. And, all I'll say about that, and I might say a little bit more, is that it sounds intimidating at first, but all of my patients who started self-cathing love it. And they're like, why didn't I start doing this earlier? I feel like I have so much freedom. This is so easy. I can empty my bladder. So it's something to always think about. There are forms of electrical stimulation and implants that some people use, and Botox injections can actually be very helpful. This is something a urologist would perform and do. So let's circle back and talk first about just some lifestyle modifications. The first thing to think about is just dietary changes, right? So there's so many things that we consume that are very irritating to our bladder. It's not just caffeine and coffee, which some of you might know is very irritating to the bladder, but actually alcohol and pretty much all carbonated beverages and artificial sweeteners, all of those things can irritate the bladder and cause that bladder to just sort of spasm and give you that sensation that you really, really have to go. Maintaining a healthy weight is also really important. Excess weight makes all these symptoms worse. Smoking makes these symptoms worse. And finally, I always tell my patients to wear the right pads. Some people are wearing menstrual pads, and those are not meant to absorb urine. They just don't work. So in the next aisle over at the drugstore, or if you keep going in that aisle, by the menstrual pads are urinary incontinence pads, and they're so much more effective. I want to just briefly talk a little bit about some of the medications, just so you've heard the names. Many people might be familiar with the medication oxybutylene. It's a generic drug. It's inexpensive, but sometimes people have to take it multiple times a day for it to really do its job. There's a whole bunch of other medications. There's tolterodine. The brand name for that is Detrol. Fesoterodine, which the brand name is Toviaz. One of my favorites is Trospium. The brand name for that is Sanctura, but it's now generic. So there's a lot of different choices. And there recently was another new medication that works in a slightly different way, and it's called Mirabegron, or the brand name is Mirabetrix. And the nice thing about this is it doesn't cause those same side effects that some of you may have experienced if you've ever been on oxybutylene, which causes dry mouth and constipation. So there's a lot of different choices, and these are things that you can talk to your doctor about to find which is the best one for you. I will mention this botulinum toxin or Botox injections can be very helpful for some people, but sometimes it works so well because it totally relaxes the bladder that people can't completely void on their own. And those are the folks that might need to use intermittent self-catheterization. So, I don't want to I want to save a lot of time for questions, but I want to move on to talk a little bit about bowel problems. So, bowel issues are complex, and basically because it's a complex series of nerves that control our bowels, and motor fibers in our colon have to sense the stretching of those smooth muscle walls and cause internal sphincter to relax. And then when it's socially appropriate, those neurons have to trigger the external sphincter to relax and have the ability to void. So basically what I'm trying to say is our entire colon and all the contractions and sphincters, it's all controlled by our nerves. And all those messages are coming to and from the brain via the spinal cord. So there's sensory and motor nerve messages that go from the bowel to the spinal cord to the brain and then back to the bowels. So any of these functions can be affected by NMO because everything that's trafficking through that spinal cord could be affected if there's a lesion there. So what happens when things go wrong? What are some of the symptoms? Well, a lot of people have constipation. Some people have urgency and incontinence of their bowels and can have, fecal incontinence. And a lot of people have a mix of both of these things, of constipation plus urgency. And these are extraordinarily common. And, if you look at the data and all the research, it's actually quite poorly done. And so the prevalence of these things, and we look at MS for a lot of this data, but even because there's been more studies on it, but even those are there's not a lot. And so the estimates of prevalence are so wide. But when I talk to my patients, almost everyone has some issue. So these are really, really common problems. So please don't ever feel that you're alone. But other factors that can add to the problem, a lot of people, to help with their bladder symptoms, might try to drink less, which is not necessarily the right answer, to drink less water, because if you drink less water, that can actually also cause constipation. And so it's a tough balance. Some people may have motor issues and might have difficulty even getting to the toilet. And then, of course, there's all these other medications that the side effect can be constipation. I just mentioned all these anticholinergics that we used for the bladder, but one of the side effects is actually constipation. So it makes it tough, and so that's why you have to find the right combination of medications and treatments with your doctor. So what can we do about it? Well, there's the lifestyle things. With constipation, there's a lot of behavioral modifications we can do. Drink lots of fluids. We can exercise. Eating lots of fruits and vegetables, and things like prunes, like that can really help things get moving. And I also tell people, get in the right position. We're, as humans, we actually, like when we were cavemen, we were not sitting at a 90-degree angle on a toilet. And so what some people find is actually more helpful is when they sit on the toilet, they stack a bunch of books so that it sort of changes the angle from a 90-degree angle where they're sitting to more of an acute angle, like a 45-degree angle. And that actually can really help get your bowels out. So it's, something to think about. And then what about medications? Well, there's a few, right? There's different ways that these things work. For constipation, we can bring more water in, and that's with things like polyethylene glycol. The brand name for that is Miralax, and that can be really, really helpful, and actually my number one recommendation. Colace, or is Docusate. To be honest, I think polyethylene glycol is probably more effective than Docusate, but that's for you to decide on an individual basis. Then there's stimulants. There's things like senna or bisacodyl. Those are things that actually cause the bowels to contract, but sometimes people think that this can lead to some cramping sensations too. And then there's a whole nother sort of set of tools if you need to produce a bowel movement quickly. And so glycerin suppositories are sort of one of my favorite things to use. They're not stimulants, but they can sort of help to soften the stool. And it's basically soap. So it's not even a medication, but they're these little suppositories. And if you use them, it will sort of help clear out whatever's in the rectal vault pretty immediately. And this can be really, really helpful also for people that are worried about incontinence, because if you know you're going to be going on a long car trip or going to be on an outing, and you don't want to have an accident, you can make yourself have a bowel movement in the privacy of your own home. So lots of different choices on that front. I feel like I'm talking so much, but before we get to questions, I want to just briefly talk about sexual problems. So the first thing to say, again, our sexual problems are very, very common. This is a huge issue for our patients. So again, do not feel that you're alone in this way. And even this is common in MS too, which is another population of patients I talk to. And ignoring these problems can lead to major issues in quality of life. So what can go wrong? Well, sexual arousal begins in the brain, and the brain sends messages to our sexual organs along all the nerves running through our spinal cord. So again, if any of those nerve pathways are damaged by NMO, the sexual response can be affected, including arousal and orgasm. And then there's other factors that are also at play, like the spasticity that people might be experiencing, or even other psychological factors related to self-esteem or mood changes. So the way I like to think about sexual dysfunction is primary, secondary, and tertiary. So primary sexual dysfunction is really changes, and this is for men and women, by the way. It's not just men that have sexual dysfunction. I should have mentioned that ahead of time. Men and women have these problems, and men and women have primary, secondary, and tertiary sexual dysfunction. So primary sexual dysfunction are changes that directly affect libido or sexual response due to direct damage of the nervous system. So people, for example, that might have decreased sensation in their genital area. Secondary sexual dysfunction is related to all the other symptoms of NMO, like the muscle rigidity, weakness, spasms, even bladder problems that make it challenging or decrease your sexual desire in some ways. And tertiary sexual dysfunction is all the emotional and social and cultural aspects of NMO. Per the media, we're all supposed to be young and beautiful and highly sexually active. And, the way two partners define intimacy might be different for each person. And most people are dealing with all three of these things at once. These do not, are not single, isolated things. So how do we deal with this? Well, it starts with open communication between you and your provider. And this might require a multidisciplinary approach, but with urology and neurology and nursing and social work and psychology, because it may take a lot of folks to sort of help figure out what's going on and what the problem is. The other thing I always say is look at your medication list and talk to your doctor. There are so many medications that we use that affect libido, lubrication, and even cause fatigue. And if you're feeling really fatigued, sex is not the number one thing on your mind. And again, it's really important to maintain a healthy lifestyle. And finally, communication with your partner. How do you define and maintain intimacy? And what are your expectations? And what's your partner's expectations? I think these are really, really important topics and conversations to have. But more specifics about some medications, when we think about sexual problems with men, Potential problems include difficulty achieving or maintaining an erection, difficulty ejaculating, or decreased or reduced sensation. And so the potential treatments, the number one choice are these oral PDE inhibitors. The most common one is that you may have heard of is sildenafil. The brand name for that is Viagra, or tadalafil. That's Cialis. And even patients that have sexual problems due to NMO, most people will still respond to those medications. There are second and third line treatments, including intracavernous injections and surgical, implantation, but those are used in other cases. But what about women? So potential problems in women can have reduced sensation. They can also have painfully heightened sensation and vaginal dryness. So what are some potential treatments? Lubricants, especially water-soluble lubricants, can be very helpful for dryness and for pain. And for some women, especially postmenopausal women, estrogen replacement therapy can be very helpful. There have been some studies looking at sildenafil or Viagra in women. The studies are sort of mixed. Some say it increases arousal, some say it increases lubrication, and some say it doesn't do much. But it seems to be safe, so it's something also to talk to your doctor about. So I want to make sure that we have plenty of time for questions. So I've talked about bladder problems. I've talked about how normal bladder function should work, and then all the things that can potentially go wrong, and what some of the treatment options are. And I've talked about bowel problems, and again, normal function and types of dysfunction and potential treatments. And then finally, we've talked about sexual problems and some of the common issues in men and women, and some of the potential treatment options. So I want to open this up to questions, and please, don't be shy. It's these are really, I know these are really sensitive issues, and I'm happy to talk about it. So let's see. I have a question here that says, I think someone was describing that they felt that this was they had a similar sensation to this detrusor sphincter dyssynergia, and say that happened to me. I feel the urgency to go, but then it can be minutes that I sit on and nothing happens, and then I have to quote run. This is a really, really common problem, and maybe this was about bowels, actually. I'm not sure, because then Sumaira suggested the squatty potty. So the squatty potty, I have no endorsements of any products, but this was something that was featured on Shark Tank to really show people that if you change the angle of how you sit on the toilet, it can really help get things out. And I just suggested a stack of books that you can just sit and angle your legs in that way. But there's other people have been thinking about this too, not just for people with NMO. And it can be very stressful. And someone wrote, I was paralyzed almost 3 months. I feel small, nothing like that before. So I'm not sure if this is in response to sexual dysfunction, but I just want to reiterate that this is a huge problem. One of the most common problems with any sort of spinal cord injury can be erectile dysfunction, and it's such a challenge because people don't talk about it enough, and people often don't get the treatment that they need for it. And these medications that are used for erectile dysfunction can really, really help. They can help people even who have had spinal cord injuries, because basically what they do is they allow more blood flow to go to that area, and help things work just a little bit better. Um, Someone wrote, let's see. Um, the night before I relapsed, I spent the entire night going to the bathroom, feeling the urge to pee, but nothing. And then the next morning before treatment, the feeling disappeared. Yeah, so this is also, I think this is just a great comment, because one of the confusing things about bladder problems with NMO or any spinal cord problem is we get mixed signals. We get such mixed signals to our bladder. Sometimes, I mentioned the bladder usually fills to capacity, which is like 600 milliliters, but sometimes it'll fill to like, just this much. And someone will get the urgency to go, like, I really, really got to go. And then they sit on the toilet and like, nothing comes out because the bladder's like spasming. And other times people get the sensation to go because the bladder is so full and they can't get it out because the sphincters will not relax. So both can be a problem. And so that's why it's really important to sort of figure out what is the problem. And the unfortunate thing is we can't always trust our symptoms because our symptoms can be deceiving. And so sometimes it takes a visit to the urologist to have what are called urodynamic studies, where they do all these sort of tests and look at, how is your bladder contracting and what's the velocity of the flow of your urine, to really figure out exactly what the problem is, because then we can target the treatment in a much more effective way. So I actually work pretty closely with some urologists because it sometimes takes a multidisciplinary approach. There's a question of is there something to increase sensitivity and control of the anal sphincter muscle? That's a really good question, and the problem is not really, and that's why this can be challenging. So, for a lot of patients that are having these issues with fecal incontinence because the anal sphincter is just not doing what it wants to do, this is when I recommend these glycerin suppositories. So I had a patient who she's very ambulatory, or meaning she could walk just fine, and she actually would run. And she said the problem is whenever I go for a long walk or a run, I have to go. I have to go really, really bad, and then I know I'm gonna have an accident with my bowels. So then she didn't want to leave the house because she thought that there's going to be a problem. So I said, what if you do this? What if you use a glycerin suppository? 10 minutes before you're going to go out for your walk, or 20 minutes before you go out for your walk, you'll have a bowel movement within 10 minutes. You'll empty whatever's there, and then you'll be able to go on your way. And since she started doing that, she's like, it's changed my life. And I said, if your bowels are not in control, you need to take control. And that's what we have to do with everything, right? NMO makes us feel like we're out of control in so many ways. But we can take control over a lot of these symptoms. Let's see, there's more questions here. With regard to birth control, I know it is now common for a lot of women to have implants, etc. But given that with most NMO treatments, you are immunosuppressed, does that not put you at risk for developing infections with those types of birth control, with those birth control implants? So I'm thinking that this person might be talking about IUDs. An IUD is a very specific type of birth control where it's something that's inserted into the uterus, and this does not at all change your risk for a UTI in any way. These implants, these IUDs, are in the uterus, and so they're completely separate from anything related to the bladder. There's, if you look at a female anatomy, it goes bladder, uterus, rectum. And so the goal is there's no contact between those two things. And the other thing to say too is, there's quite a bit of normal vaginal flora and that is meaning normal vaginal bacteria, and that is not the type of bacteria that will cause a UTI either. So that's a really good question. And yes, there are so many different types of birth control. And some people, this is sort of an aside, but some people feel different and have their NMO symptoms feel different with different types of birth control. And I've seen it every way. Some people say I feel better when I have a little bit of estrogen, meaning, from the birth control pill. And some people say I feel better when I don't have that. So those are all things to think about and talk to your doctor about. Is it common for men to experience erectile dysfunction with NMO, and is it something male patients can regain even if they're not paralyzed? So first of all, yes, it's very common, and it's very common in patients who are not paralyzed. You do not need to be paralyzed in order to have erectile dysfunction. It's just common and affects so many people. Is it something you can regain? It depends. It depends on the extent of the damage in the spinal cord, but it's even if you can't regain it naturally, it is something that can often be helped by medication. So again, there's lots of medications that can help with these problems. And if medication doesn't work, there's the second line treatment are these intracavernous injections that men can inject themselves to cause an erection. And finally, there's sometimes surgical implants to help produce an erection. So it's there's plenty of treatments available. Someone wrote, I was recently in the ER because of frequent bowel movements, nausea, vomiting. The ER doctors was convinced that it was GI, but I'm always concerned about NMO whenever something comes up. So that's a really, really good point. So, for those of you who don't know, NMO, sometimes even the presenting symptoms of NMO can be nausea, vomiting, and all sorts of GI side effects because there's a specific area in the brain. It's called area postrema. It's actually your brain's vomiting center. And for whatever reason, NMO really likes that area. And so, sometimes there can be, an NMO inflammatory lesion in that area and cause people to have things like nausea and hiccups and vomiting. And it often gets mistaken as a GI problem when it's not. It's a brain problem that you can even see sometimes on a brain MRI. You can see that area of the brain sort of lights up. So it's always something to keep in mind. It typically, increased bowel movements are not necessarily associated with the area postrema syndrome, but it's important to think about NMO when it comes to any GI symptoms. And someone wrote, thank you so much, Doc. This series was super helpful. I just want to reiterate that these topics are so important and so sensitive, and we don't talk about them enough. And to be honest, I don't think neurologists ask about them enough. And neurologists should be doing a better job. And we should all have these things on our radar, because these are the symptoms that truly affect our quality of life in such a major way. So I please don't be shy to talk about to your doctor about this. And your doctor may not have the answers. I talk about these issues all the time, so at least I sort of feel like I know how to get the help that people need. But sometimes it might take seeing a different provider or something to really get the help you need. And again, I didn't go into all the details about all the different types of bladder treatments, but there's one class of drugs that we use called these anticholinergics. But again, some of the side effects can be dry mouth, constipation, but then there's a whole nother class of drugs that we use that help get the pee out, that help you void completely. And some of these medications were originally approved for men with big prostates, but I use them for my female patients all the time too, because what they do is they help relax the urethral smooth muscle and help get all the pee out. And then I mentioned this other type of medication, mirabegron, which is another medication that helps to relax the bladder to allow it to sort of fill to capacity and just be like a loose balloon to get bigger and bigger. And that can be a really helpful medication. One important thing though to think about, which we also don't talk enough about, is some of these medications are branded and some are generic, and so the price point can be really different. Like I really like mirabegron, but it's can be very, very expensive for some people. So then it's not an option, right? So we need to sort of think about, take all those things into consideration, and use all those things to make that decision. Someone just wrote, is there a negative to using glycerin suppositories to regulate bowels? Honestly, no. A glycerin suppository is essentially soap. It's just soap. It doesn't, it's not going to affect your bowels, your colon in any way. It just makes whatever is in there slide out. The only caution I will say is don't do it unless you're close to a bathroom, because you're going to have to go really, really soon. It's going to make you have to go. So, make sure that you are by a bathroom and do it. That's something you get to do in the privacy of your own home. Now, a lot of us are at home anyway, so that makes everything a little bit easier. But these glycerin suppositories come in like a cylinder like this, and you can buy them in packs of 50 or 100 at the drugstore. And the other wonderful thing is they're really inexpensive, so it's a very nice solution. Someone wrote, are there any female equivalents of Viagra for female patients? So not really. Unfortunately, there was one drug that was, has been tried and approved for female sexual dysfunction, but I don't think it's been that helpful, to be honest. And it's so. And as I mentioned too, some women actually do use Viagra, and Viagra itself might be helpful for some women, but that's a conversation to have with your doctor. But female sexual dysfunction is such a more challenging problem to think about, because it can manifest in so many ways. And sometimes it's not just about adding another medication to fix the problem, it's figuring out what's the root of the problem. Because if there's a lack of libido, for example, oftentimes that's from a side effect from other medications someone's on. For example, some antidepressant medications in the class of SSRIs, yes, are great to help depression and are really, really useful medications. But one of the side effects is it can decrease your sexual desire. So, or some people use gabapentin, which is a medication to treat neuropathic pain. That also, can kill your libido and make you really sleepy. So, I think when it comes to sexual dysfunction with women, it's not always about adding a medication to fix the problem. It's understanding what's the root of the problem. So let's see. Someone also wrote, how often should someone be taking Miralax? That's a great question. And my answer is, if you're having constipation, take it daily. Take it daily. Because if you just take it as needed, sometimes it's not as helpful. And some people are like, well, I took it and nothing happened. But if you're taking it on a daily basis, just like a capful a day, that can really help to regulate your bowels. Because one of the other issues with bowels is that, you can sort of get into this cycle where you can have constipation for several days, and then on like the fourth day, and you haven't had a bowel movement in 3 or 4 days, then all of a sudden you're so backed up that you get this urgency, and you can have an accident. So, our goal is to sort of think, well, how can we regulate these things so we can have a regular bowel movement, hope every day or every other day. And every day may not be normal for everyone. Don't think you're abnormal if you're an every other day kind of person. Some people are. Some people are or twice a day kind of person. And all of those are within the realm of, normalcy. We just need to achieve some normalcy for you. Let's see, someone wrote, I have noticed that since the diagnosis, when I get normal heavy flow periods, general period pain is more painful than it used to be prior to my diagnosis. Could this be the after effects of a spinal cord lesion? That's an interesting question. Many people might realize that a lot of sort of nerve signals are just different after a relapse. And some people can have neuropathic pain or heightened sensation, and some people have reduced sensation. But the other thing is, the reason that periods can be painful is that uterus is just contracting, and it's just this crampy, bad pain. So, it's hard to say whether this could be the effect of a spinal cord lesion, because it sort of really depends on where the spinal cord lesion is. But it could also just be that, people after a spinal cord injury, people's nerves are more sensitive in many ways. And sometimes even things like soft touch can be painful. And I don't know if anyone's ever had that experience, but I've had patients say, like, even being in the shower, it feels like it's like raining needles on me, or I can't wear my socks because it's painful. And so, anytime we sort of have something gets disturbed with those messages of where all those nerves are going and coming, it can sort of change our sensation in different ways. Someone wrote, do suppositories hurt? No, they really don't. It's like this tiny, tiny little small piece of, soap that's like this. It looks like a little bullet. And people just, you can put a glove on and, insert it into your anus, and it's really, it's at first it might feel like a weird sensation if someone's never had that, but it's not painful. It should not be painful. Someone asked about Linzess. That's a really good question. So I've tried it for my patients, and I've seen mixed results. Again, I'm not here to endorse or disparage any products at all. That's not my role here, and so this is something to decide with your doctor. But some people have found it to be completely ineffective, and they're like, "What? This is super expensive. I don't know why I'm paying for this. It's not doing anything." And some people have found that it caused diarrhea, like all the time, and did not like it for that reason. So again, I'm not here to endorse any product. I'm just sharing the experiences that some of my patients have had with this medication. Are bladder and bowel dysfunction more prevalent in female versus male patients? So that's a really good question. Both men and women have both bowel and bladder problems. And it all sort of depends on where the lesions are in the spinal cord, really. But women have a few unique considerations. And one is that because of the shorter urethral length, they're more likely or more susceptible to things like urinary tract infections. The other thing about women that makes life a little bit more challenging is for those who are paralyzed or bedbound or wheelchair bound. Women don't have a reliable collection device. Like men can use a bedside urinal, they can use things like a condom catheter, and women cannot. Women even have a hard time peeing in the woods, right? So as a consequence of that, women who are more disabled and in a wheelchair or bedbound are often more likely to have an indwelling Foley catheter. And that alone can be a huge source of infection sometimes. And so, it's not always, but it can be. So, we have to just be extra careful and kind to our women, and make sure that we're taking care of this in the cleanest, safest way. Someone wrote, I am listening to this for my daughter since she's at work. Is it possible to listen to this later? I believe this will all be posted on YouTube. So it will hopefully be available for anyone to listen at any time. And someone wrote, yes, soft pillows feel like sharp steel. Yes, this is such a common thing, right? Like our sensations get sort of changed. And I think, another reason that this is such an important comment is because this can have a huge impact on sexual function, right? When your partner is, softly touching you, for example, that might be painful. And then if you express that you're in pain, then your partner's uncomfortable, that the partner didn't want to make you in pain, and it can cause this sort of strange dynamic or uncomfortable dynamic between two partners. And so this is why it's so important to have really open communication with your partner, about what feels good, what doesn't, what are your expectations, what are his or her expectations, so that everyone's sort of on the same page about these things. I think Sumaira just wrote, yes, this will be uploaded and available to view this afternoon on both YouTube and Facebook, which is wonderful. And then Sumaira just wrote, time for one more question. So I'm happy to take one more question. Or just keep telling you guys all of my thoughts about all of this. I really, like just sort of telling you all the things that I'm thinking about that I wish I could tell to every patient, because again, these are such important things to be talking about. And the final thing I'll say is that these things are not exclusive. Most people that have bladder problems also have some form of bowel problems and also have some form of sexual problems. And again, these things can all be interrelated. This is a very good question. Can methanamine hyperate lead to chronic yeast infections, and can it lead to medication-resistant UTIs? So for those of you who are unaware, methanamine is a medication that sometimes people use to help prevent UTIs. The first thing I'll say is methanamine has not been studied in patients, to my knowledge, has not been largely studied in patients with NMO or neurogenic bladder as a way to prevent UTIs. And I will also say, for a lot of people, it hasn't worked that well to help prevent UTIs. Theoretically it should, but it doesn't always work so well. Can it lead to chronic yeast infections? It should not, but everyone is a little bit different in that way, and things that trigger yeast infections are a little bit different for each person. And it should also not necessarily lead to medication-resistant UTIs. One thing that can lead to medication-resistant UTIs is the chronic use of antibiotics. And so, for example, some people are told to take nitrofurantoin, which is, the brand name is Macrobid, as a preventative UTI antibiotic. And there is some evidence that if you take that daily, that can potentially lead to resistance with some UTIs. So that's a really good question and a very interesting topic of further research. But thank you all so much. I think we have just a few more minutes. But again, what I just wanted to say is that these are really common problems, and they're really sensitive topics. And so, if your doctor doesn't ask you about them, you can bring it up. And I it's someone wrote one last question. When a person has constipation, besides Miralax and Colace and the other medications that are recommended, is there anything else a person can do to help constipation? Kind of like something like Botox. Um, so there's nothing that's like a long-term treatment like Botox. Um, it, but again, even changing your diet can make a huge impact, can have a huge difference. Changing just the ratio of how much fruit you eat in a day, or dried fruit. um, all those little things, even a fiber gummy here and there, um, can really help with constipation. I think those are sort of the best long-term non-medication types of solutions. um, so there is hope for constipation. The one caution though I'll say lastly about fiber is people are always told to take fiber. Well, fiber helps to bulk things up, but it doesn't help things move. So you can take all the fiber you want and you still might be constipated. So you need to take fiber plus something to sort of help things move along their way to get out. So I hope that this was helpful to folks, and I'm glad that this is going to be posted for other people to view, because these are important things to talk about. And again, if your doctor doesn't bring it up, it's okay for you to bring it up. And I'm please reach out to on Facebook, and for more questions, you can hopefully post things on when this is posted. And I'm so glad I got to talk with all of you. So thank you very much.